Hello everyone, I hope you all safe. This is Dr. Nerd. I am Asma and I'm going to talk about continue talking about valvular heart disease covering rheumatic fever and infective endocarditis. So what happened to you? What is rheumatic fever? Let's talk about this story. There is a patient who got a pharyngitis or a tonsillitis, and then and it was a group A beta hemolytic streptococci or streptococcus pyogen who caused this infection. Then 2 to 4 weeks later, the patient started to get some symptoms. They have a joint pain, they have fever, maybe this patient have some confusion. So these symptoms that happen 2 to 4 weeks later, they are collectively called the rheumatic fever. So this is a group of symptoms. What is now the cause of these symptoms? The cause is an immune reaction or an inflammatory reaction. So it's not the bacteria itself, it's not the group A streptococcus itself that go to the heart or the tissue that cause the damage. No, it is the immune system that confused one of the group A streptococcus protein with our tissue. So group A streptococcus, they have a protein called an M protein, and during this bacterial infection, our body tried to fight it by forming an antibody. But also in our heart, there are some protein, which is the myosin protein, that present in the cardiac muscle that looks similar like M protein. So our body confuses it and think that this myosin protein is the enemy and attack them in the heart, and that's what causes the cardiac manifestation in the rheumatic fever. In general, the cause of rheumatic fever, it's not fully understood, and this theory, which is called the molecular mimicry, that's meaning that one of the M protein mimic one of our body protein, is a theory, but it's still not fully understood. Now, who is at a high risk to get rheumatic fever? Patient who get the infection itself, patient who get the infection and did not get the antibiotic, which is penicillin, and also a patient who get the infection at the age of 5 and 15 years old, meaning they get the group A beta hemolytic streptococcus infection between 5 and 15 years old, or patient who live in a resource limited countries where they don't have access to a good healthcare system. So we said that group A strep infection can happen either as a form of tonsillitis or pharyngitis, or it can happen as a skin infection like impetigo. What are the signs and symptoms? So how can these patients present who have a rheumatic fever? I combined the presentation with the diagnostic criteria because it's easier to understand them this way. So what are the diagnostic criteria? They are collectively called Jones criteria. How do I remember them? I think of Jones like it sounds similar to joint, and one of the causes that cause joint disease is rheumatoid arthritis, and rheumatoid sounds like rheumatic, and this is how I keep rheumatic fever. We diagnose it with Jones criteria. Now, what are the components of this criteria? First, J indicating joint, which is migratory polyarthritis, meaning and usually it affects the large joint like the knee and the hip. The patient will come to you having a knee pain. Few days later, they will have a knee pain in other side, or they will have a hip pain, and so on. The O, we say the O look like a heart, and the patient can have pericarditis. So inflammation in all the layer of the heart, and it has a different manifestation. The patient can have a manifestation of pericarditis, or they can have a manifestation of regurgitating valve, and so on. And indicating subcutaneous nodules. So these nodules, they are firm, they are They are painless and they are present in the extensor area. E indicating erythema marginatum, which is the skin discoloration looking pink or reddish with the central with a central clearing, and that's why it's called marginatum. S indicating Sydenham chorea, which is a Chorea, it's an involuntary movement that is indicating CNS damage, and so when a patient comes to you when he's a child and he starts having an involuntary dance-like movement of their limbs, and you should ask in the history if this child got a sore throat a few days later, or a few days or a few weeks ago, to see shall you consider rheumatic fever or not. There are other minor criteria, which is polyarthalgia, pain in the joint without an inflammation, fever, increase in acute phase reactant like CRP, and increase in PR interval, which is an indication of a cardiac involvement. So we diagnose patients with rheumatic fever if they have 2 major criteria, or 1 major plus 2 minor, or 3 minor criteria. So this is the fever itself. And remember, we said that the heart involvement is one part of it. And the heart involvement is what we call the rheumatic heart disease. If it's acute, it's due to the endocarditis, and usually those patients will have a regurgitation. But when the patient gets cured from the infections, and the heart tissue start to heal and form fibrous tissue, and that make the valve more prone to stenosis, and this is the chronic valvular disease, forming the chronic valvular disease. So when you hear a rheumatic heart disease, you think either the patient has an acute fever now and he has a sign or symptom of endocarditis. In the context of valve, the patient can have regurgitation. If the patient had does not have a rheumatic fever now, but he had a history of rheumatic fever, this patient most likely could have an stenosis. What are the valves that get affected during rheumatic fever? The most common one is mitral valve, then the aortic valve, then least common the tricuspid valve. Now, we finished from the rheumatic fever. Let's talk about the infective endocarditis. Remember that we said the rheumatic fever, it is not the bacteria itself, but it's our immune system that confuses, that think that our tissue is the enemy and attack it. But in infective endocarditis, from the name, it's an infective. It is the organism or the bacteria itself that go to the heart tissue and attack it. From where do the bacteria get an access to the heart tissue? From the blood. So bacteremia, meaning there is a bacteria in the blood. How did the bacteria go into the blood? From any source. It could be from the mouth, or it could be from bacteria in the GI system, then went to the blood, or bacteria from the skin, or from the genitourinary system, and so on. So when they get access to the blood goes through the heart, and especially if there is a damage to the heart, they make them more prone to the attachment of the bacteria, and then these bacteria form a colony there, and they damage the heart. So in addition to the damage to heart, there are 2 types of consequences that can happen. To understand them, think this is the heart, and these are the 4 chambers of the heart, and this is a valve. Think of it as a valve. So what happened that the heart, the bacteria form a colony, and there are vegetations on the valve, okay? And there are some damage to the valve, and there is some erosion of the valve. Okay. So what happened now? Some of the tissue, like collagen, get exposed, and these rough surfaces make the platelet get activated and form a fibrin clot. So now there is a clot on this valve. This clot can separate at any time and form an embolism. And this embolism can go and lodge anywhere in our vascular system, resulting in a thromboembolic event. This is the first thing. The second thing that can happen, our body tries to fight this bacteria by forming an antibody and immune complexes. These antibody and immune complexes can go and attack or get lodged itself in other in other parts of the vascular system, resulting in antibodies and immune complexes. And remember these because these are one of the signs, and we usually get asked about the sign and symptom. Are they thromboembolic or they are an immune complex? And also they form two of the minor criteria that we use it to diagnose infective endocarditis. Now, who is at a higher risk to get the infective endocarditis? Patients who are male and older, patients who had a damaged valve or a heart, whether it's congenital or acquired, and patients who have bacteremia, such as an IV drug user and patients who undergo a dental procedure. So what happens in IV drug abuser when they use a needle and they share it between each other, or they do not use it in a sterile manner? They introduce the bacteria into the blood, and when they introduce the bacteria, they introduce it into the vein because it's an intravenous drug. It's go into the vein, and if you follow how the blood goes from the vein, then it go to the superior vena cava or the inferior vena cava, and we'll assume this is a heart, and it's got here like there to the right atrium. What is the first valve that gets encountered? It is the tricuspid valve. So patients who are IV drug abuser and having infective endocarditis, the tricuspid valve is the most likely. The tricuspid valve is the most common valve that gets involved. For the dental procedure, there are bacteria in our mouth called the viridans streptococcus, and when there is a manipulation or extraction of a teeth, they get an access to the blood. So for infective endocarditis, based on the pathology and the organism that they cause the disease, they are divided into acute and subacute. Acute, they develop very fast through days, and patients have a severe symptom, and it results in a high mortality. And usually the organism is a high virulence organism, such as Staph aureus, and it's the most common cause of acute infective endocarditis. And since it's high virulence, it can affect normal native valve. Native valve meaning it's not a prosthetic valve. For the subacute, meaning that it will take time until the disease fully develop, and that it will take weeks. And usually it results in a less severe symptom and low mortality, and it's usually caused by a low virulence organism such as viridans streptococci species. As we said, the source is the mouth, and since they are low virulence, they need a prerequisite, which is a damaged or abnormal valve to get attached. So we discussed what is the pathology and the type and acute and subacute, and who's at a higher risk. But how we identify the patient who have infective endocarditis? We use a criteria called the Duke criteria, and they also divide it into major and minor criteria. For the major criteria, we need only two things. First, we need to establish that there is a bacteremia in the blood by taking blood culture, and we have to have a two positive separate blood culture. The second thing, we have to have an evidence that the endocardium gets involved in the infection, and that's by performing an echo. And if we see a vegetation or abscess or a new regurgitation, that indicate that the endocardium gets involved, and it has to be a new regurgitation. For the minor criteria, there are 5. The risk factor, we discussed it: fever, vascular abnormality, and immunologic disorder. We discussed how they happen. We will have an examples in the next slide. Microbiology, that means that we did a blood, we took a blood sample and we did a culture, but the organism that we collected, it is not typical. We collected an organism, a bacteria, but it's not typical for infective endocarditis. If it's not typical, we say it's a minor criteria. So when we diagnose patients with infective endocarditis, if they have either 2 major criteria, 1 major plus 3 minor, or 5 minor. Now, Come to the sign and symptom of infective endocarditis. In addition to the sign and symptom that we said, it is from the heart itself, the heart infection of itself, whether it's cause an regurgitation or stenosis. There are other signs and symptoms that related to the immunologic and a vascular abnormality. Vascular meaning the thromboembolic that we discussed. There are two main immunologic disorders. The first one is the glomerulonephritis. So a patient who have a heart problem and you are suspecting infective endocarditis, then this patient gets decreased urine output, or there is a blood with the urine. That may indicate that the patient is developing a glomerulonephritis. The second one is osseous nodes. Osseous nodes, they are nodes that present in the bad parts of the finger, and they are painful. And I remember that osseous is painful by remembering when we have a painful thing, we say ouch, ouch, opening our mouth like an O, and that's why how I remember osseous is painful. Usually, the doctor asks us to compare between genuine and osseous, genuine lesion and osseous node. You can see osseous is immunologic. Genuine is a vascular abnormality, but in addition to that, genuine, they are a lesion, so there is no node, and it's present in the palm, and they are painless. Other vascular abnormalities, so when this embolus go to the eye, to the retinal vessel, it result in a Roth spot, which you can see it in the fundoscope as a bleeding with the central clearing. Then when it's go to the finger, to the nail, it forms a splinter hemorrhage. When this embolism go to the central nervous system, it can form a stroke. When it go to the lung, it form a pulmonary embolism. When it go to the spleen get congested and become larger. This was the last slide for infective endocarditis. Thank you for your listening.